We're joined now by Lisa Wilton, an award-winning advanced nurse consult. I've got that slightly mixed up. A nurse consultant in the Office of the Chief Psychiatrist with over 37 years of mental health experience. She led statewide initiatives including South Australia Health's mental health general practice shared care model of care. My God, these are big titles, aren't they? The metabolic health program, the nationally recognised clozapine training and nurse-led clinics. We've got April Symes is a data queen, I will say, senior business analyst for South Australia Mental Health Clinic program and the Office of the Chief Psychiatrist. Extensive experience in mental health and other health data sets, data warehousing, reporting tools, the whole bit. These two are a force. Let's hear from them. Welcome, Lisa and April.
Thank you. And might I add, it's always hard to follow Ian. But they did the best segue ever with needing to go and do some technical work there. So thank you very much for having us. Now, which one do I press? The green one, the green firework. Okay. Did that work? Not that one. The top green one, the one with the big green arrow on it. Yeah, that's better than the firework. Okay, of course, we'd like to acknowledge the Kaurna people and our lived experience as well. So we're here to tell you about the plan. So our presentation today is a very quick overview of the mental health operational data domain. Now, a bit of a caveat here is that we would have loved to have shown you this live, but due to confidentiality, we couldn't do that. So you have to put up with screenshots and a little bit of animation. But we're going to look at the issue that we had here in South Australia and the unique opportunity that we had to be fortunate enough to have some very talented people, April being very talented here next to me, to design, create and realise a solution to a problem that we had. But first of all, I'll just let you know about our digital landscape in South Australia. So some of these, I will use the acronyms, but let's explain first. So our Open Architecture Clinical Information System, we call it OASIS. That's our original and still utilised, the one-stop shop for blood results, location of a person, alerts, and where we generally pull the data. The issue with this one is that all the reports required are manually processed, which meant, for example, once we put our clozapine alert, which Scott showed you a little bit from that data yesterday, if someone was admitted to hospital on a Friday night and then discharged by Sunday, they didn't show up on the reports because the reports are manually run Sunday through Friday. The next one is our community-based information system, or CBIS as we call it, and that's specifically customised for SA Health use, and we have internal people who build the screens, create the reports and respond to our ever-changing reporting requirements, and it's generally Tammy and I going, can you do this? And they go, sure. And then we have our country version of that, which is our Country Consolidated Client Management Engine, or CCCME as we call it, which is the country version of CBIS. And then, of course, we have our electronic record as well. So prior to Sunrise is our inpatient services medical record. We all used CBIS for both inpatients and CCCME for inpatients and community. Now, the thing with the CBIS, CCCME and Sunrise systems is that they don't actually talk to each other. And what we actually say is CBIS has no friends. And while Sunrise can actually import some CBIS reports and services, it's limited to about 10, and they're not live. So all of these systems also have a unique identifier number. So to collate or cross-match the data, all the identifiers for a person are required to be done individually, manually, which is, of course, a really time-consuming system. So what our problem was is that we needed to define the problem that we wanted a solution to, and basically it came down to not being able to identify where people were in the system. So we had no visibility where a person was, and if a person was in an inpatient bedded service that wasn't a mental health service, then we had no idea, unless somebody actually told us. and then it was usually after the fact. So we required access to multiple systems to get the data, the Sunrise, the Oasis, and there was no one domain that could actually pull all of this information together for us. And so we weren't able to be proactive about care. So we had no ability to in-reach for offering any opportunity for collaborative care. And for things like, reminding if they were in an orthopaedic ward that they had a mental health appointment coming, or if they were in a mental health unit and they needed to go and have an outpatient appointment for some physical health thing, we had no way of knowing. So we have all these multiple systems that don't talk to each other, and it doesn't provide a complete journey for the person. Now we're going to get into the technical bit. This is where my eyes glaze over. And April comes to life, and I nod very politely, and I know April's got me covered, and she has all my data once.
Thank you. Yes, thanks, Lisa. Have we switched it already? No. Top green one, right. Yep, onto it. Okay, so this is just to show you a little bit about where we started, and it's a visual of the problem that we had and what we faced. On this screen here, you can see that at the bottom, the source systems and the manual source collection, so some of those things had to be put together by reporting teams who didn't work in the same divisions, all in separate areas, probably duplication of effort, working around to create the reports required for operational business. And then they manually produced those and emailed them to people. And then those things would be emailed on. And in their journeys, what we found is a lot of the times the data would change, which leads to a difference between reporting, and that leads to no confidence in what you're getting given in the first place. So that was where we've come from. So that gave us the opportunity to bring the data together. We don't want to be asking people, which we have been doing, to create shadow episodes in different systems to duplicate data. Well, then you end up with data integrity issues. So we were very lucky in South Australia that our Office of the Chief Medical Information Office came along at a very fortuitous time for us with a whole range of data tools that they spread across SA Health. Just prior to that, when I started in SA Health in 2021, my first task was to create a business requirements document for a single source mental health data domain. I spent 12 months doing that, and at the end of that 12 months is when the Chief Medical Information Office came about with these tools. So we formalised a group. We had clinical leaders, we had the Chief Psychiatrist's Office, we had systems administrators, and we all got together to review the business requirements and make a plan moving forward. We then started to do that. This is a quick look at the build. So this is the technical side, so I'll be really quick with this. The source systems are, as Lisa mentioned, our internal systems, but we were also able to incorporate all the external data sources so that we can put these things together. So looking at data from Australian Bureau of Statistics, so for the socio-economic stats or the regional stats, the postcodes and any other AIH, Australian Institute of Health and Welfare, data sets that were relevant. So these datas would all flow in from to our data domain on a methodology which is called Data Vault 2.0, which is what is shown in this picture here. We see that the data is brought in, it's brought in raw, nothing's changed. It's staged where it's time-stamped and hash keys are applied. It's transformed, which means just adding information to the data, so that means changing a code into words that are understandable, and then having a presentation layer at the end. That is overshadowed by a system called Denodo, which manages the user access, the governance, and the auditing. And at the end of that, we then come out with a whole suite of data tables ready for reporting in Power BI. this was how long it took us. It's just a quick look at the timeline. So if we just looked straight to May 22, that was when our mental health data zone came alive. So this is what the OCMEO provided us, the Chief Medical Information Office. So the idea here was all of our divisions across SA Health doing all different bits of work. We all need to come together. So it's again, bringing us all together. So this was bringing us data people together. So everybody has a zone, and we're at the beginning of our journeys, all of us, and we're just building our domains, and we are starting to share across our divisions. So talking about things like LHNs, focusing on their data and being able to share things across LHNs and vice versa. So by March, this entire build only took 18 months, and I might say it was a team size of 1. So it can be done. It can be done. So by March 2023, we have an app auto-refreshed every morning, and it is a work in progress. It is never going to end. It's like a lot of us. That word's gone straight out of my head. All of our focuses are trying to come together. We're trying to collaborate. So that's true of us technical data people as well as you clinical guys. So by February 2024, we have a published app. This is the front page. As Lisa mentioned, we have to just show you a whole bunch of screenshots. So this is just what our front page looks at. It's bringing our data from all our sources that I mentioned before, joining the guests, and no matter where they are. So whether they have come in from inpatient, which is a Sunrise thing, ED, another Sunrise thing, or community data from our other systems. We're just going to have a quick look here. I'm just going to take you through a quick look of how it sort of works together. Looking here at, I just have to look down there so I can see. Yes, this red box is showing you where the actual menu for the reports are. So you can see a whole range there. We've got emergency, starting at the top, emergency, inpatient, the actual activity in the community, referrals, a whole lot of reports around legal orders. And then we are now going to take a look at the physical health assessment report. Don't be overwhelmed. There's a lot of information on one page here. And this is what it looks like. This first page of the physical health report is just a summary. You can see at the top, we have a number of selections and filters so that we can see what we want to see. We are here looking at 2025. And we are looking at 3 selected LHNs, which have just been blanked out for the moment. We are also looking at currently open episodes only, because we've selected yes. These 3 boxes here allow us to hone in on our community teams. So if we were a team leader, we could do that. We've selected some clozapine teams, I believe, in there, Lisa. And this first visual is showing you all of the percentage of episodes that have had a physical health assessment. And these are community episodes here we're talking about. So that's the result for the 3 LHNs. Whoops, I nearly hit the wrong button there. And we have 1,072 in total done in this selected period for those teams, for the patients of open episodes in those teams. We can do further filtering by comorbidities up here. And we also have other filters on the demographic type filters that are available at the bottom left of the page. The top chart, as I said, is showing the percentage of all the episodes that have a recorded physical health assessment across all those teams we selected from those LHNs. The bottom one here is showing you the number of physical health assessments by team. And if this was live, I could show you that. You can just sort of hover over those and see a total for all of the teams, one by one, so you can see who's the busiest team, and teams can help each other out. Where did I say? Okay, so this chart on the table on the side is just showing numbers of a breakdown by LHN. The bottom one is down to individual clients or guests. I can easily change that name to guests if we need to. And if we could see there that a whole range of clients have had 11 assessments in this period of 2025. That's all different people. When we select cancer from the comorbidities filter at the top, you can see that everything's changed on the page. The whole page is filtered for those 3 episodes that have a comorbidity of cancer for those 3 teams in 2025. This is the next view is showing an individual person. So we could have selected one person from that list and moved over to see this individual person. So this is showing us 24 and 25 for this person. Their identified comorbidities at the top being cardiovascular and cancer. The first chart on the left is showing their blood pressure that has been recorded over this 24 and 25 period. The chart to the right, oops, I forgot to press my buttons here, sorry. The chart to the right is showing the blood pressure and, the weight and waist measurements that were recorded in that time. The next table is showing substance use that has been recorded. And then at the bottom we have a boring old data dump that looks a bit like that. So, and all these data dumps can actually be exported quite easily to Excel. So that was, where am I? Back here. To return to the summary table.
I will just say that it's a bit hard to see the PowerPoint, so...
Is it? Yeah. Oh, I'm so sorry.
Yeah. So maybe talk to the themes is going to be helpful. Yeah.
Yes, we're going to be doing, yes. So I will be,
We've got 2 minutes.
So, okay, sure. Yes, heading back to the summary table. So if you prefer to see all those visuals that I was showing before, we also have the ability to just see it in a table like so. If that's, some people don't like the visuals, so we're trying to cater to anybody. Okay. We can extract all data that is feeding this summary page in one go by hitting that data table button at the top right. And again, it just gives you a boring data dump, but some people take advantage of that and use those things. So I'll hand back to Lisa to focus in.
She's taken my script.
Oh, no.
So this one here, this is the bit I really like, because we can actually see individual data showing a person's journey with the service over time from their inpatient to community. So we can actually see here where we've actually got where the high peak size generally reflects inpatient or intensive service, and then if there's some low ones, the troughs, this is around 18 months, and it's around a community stay. So we can actually see a picture over time for the intensity of a person and what services they require. And you can get pretty fancy with it, with that list on the side. You can actually, if you want to see just exactly how many case conferences that we've done, you can just click on that and it will show you that data. So there's lots more clickable things on there. Now this is where we actually got, using the Australian Institute Health Welfare Code, as April said before, that's already been built in, but we were able to pull this data of the vaccine potentially preventable hospitalisations and use this in our ATAGI presentation there. So we can see here that view shows total vaccine preventable admissions across general and mental health, and we can actually have a look to see if the person is mental health services, and then right down to how many specifically for all preventable hospitalisations, and then into vaccination alone. What happened there? There we go. And this was pneumonia and influenza here. From the previous slide, from there, we can also, this is unique, we've not been able to do this before, so we can actually see when a person's GP status has been updated. So this is where we can actually identify an individual person and their last confirmed acknowledgement that the GP is their current practice, because often we have a list of GPs and the person might not have seen them for years. So this gives us that as well. So, impossible to the possible. We've actually come a really long way with it, with all our disparate systems being collated into one, which is really useful. But we've still got a long way to go on that. And of course, it takes dedicated time. And like April's a team of one there at the moment. But there's so many people to thank. Information Performance Monitoring and Measurement Unit, colloquially we call them the CBIS team. April, of course. Liz Prowse, our Director for Mental Health Strategy Planning, John, our Chief Psychiatrist, and of course OCMEO for the tools.
Thank you so much. This is just such a powerful project, and I can't believe you were the staff member of one pulling all this together. That is phenomenal. How are you still upright?
Well,
But what a powerful piece of work that you're doing together and as a team, but also individually in your case. I will just ask, because I know it's always a concern with data, questions of data sovereignty and questions of data privacy. When government agencies have big data sets like this, and you can see yourself, in that data set as an individual being mapped and tracked, and, it's both very powerful from a service provider's point of view, but what are you doing to ensure, data sovereignty and data privacy?
yes, well,
To the mic, yeah.
sorry. Yes, for the privacy and both really, where we on the technical side have a system called Denodo that sits over all of our data. So every time that's touched, this is all cloud-based stuff. So anybody touching any piece of data is recorded within our auditable system. So everything is backwardly auditable,
Yeah.
and everything is traceable and trackable, because I've used the methodology that I mentioned, Data Vault 2.0. You are able to backtrack and right to source.
And if I was a guest of a service, I love that I just love that. Tell me what impact this sort of data set and this collation of data, this representation of data, how it could serve me, just in my journey.
Actually, when we use the whole data set, it stops you having to tell your story so many times. We can actually see where people have been. It helps us to actually in-reach and support the person better, because, if we know they've got an OPD appointment for a physical health issue, we can actually in-reach for them to that. Do you need some support to actually get there? It's not that we're blindsided, that we had no idea. More often, and South Australian clinicians, correct me if I'm wrong here, but we have people within our service and we've got no idea that they're working with the renal team or something until, it's just a happenstance conversation or something. Yeah. This actually brings it together so we can collaborate a lot better.
A question from Josie: integrating many systems into one is a monumental effort to achieve in 18 months. I'm curious to know more about strategies you use to build buy-in across your organisation levels. In particular, we often hear that time and resourcing is a barrier. How did you mitigate this? Go on.
That's for you.
And we'll just keep it brief, thanks. Because the conversation can continue at morning tea as well.
I think just being very open and accessible, and just giving people the ability, the easy way to provide their feedback, ask their questions, and also being really available to, in early stages of people
Yeah,
looking
great.
in and just having that hand hold. And I can say
Hand holding.
Yeah, that I could say from experience, it's just a one-time thing. And my biggest, one of my proudest things that I did in New South Wales was bring, in my previous experience, was bring the Aboriginal health team of New South Wales, in southern New South Wales, had no reporting ability, and they ended up being the first champions of the data
There you
domain
go.
built there.
Yeah,
So,
fantastic.
yeah.
Congratulations, and I hope that, I mean, we're a federation, but can we work together across states
it'd be
in models
lovely.
like this? Can we?
I'd love it.
Yeah, well, hopefully in this room this conversation might be initiated, because one state can be a leader and the other states can be learners and become leaders in their own right, in their own context, and their own data sets and their own systems and their own silos. Thank you very much. Congratulations to Lisa and April.